All right, I think we should make a start. So welcome everybody to the first iWiMS Neuro-Ophthalmology Group e-conference. We are very excited to be with you from all over the world tonight or in the morning. It's 2 a.m. in Australia. My name is Annika van der Walt. I'm an MS specialist and neuro-ophthalmologist that work in Melbourne in Australia. And I'm very pleased to host and chair this session on behalf of our steering committee, Dr. Elizabeth Silverman, Jennifer Graves, Sara Collorone, and Frederike Oertel. So we're going to have two talks tonight that's going to be presented. And the first one is going to be by Frederike Oertel, who is working as a postdoc in Dr. Green's lab at UCSF. She's presenting work that she did during her PhD. And the title of her talk is Visual Function and Brief Cognitive Assessment for MS, or BICAMS, in Optic Neuritis in clinically isolated syndrome patients. So I'm going to switch my video off, and Frederike, over to you.
Thank you very much. Actually, this was Sarah's title, but I think this doesn't really matter. No problem at all. So I will...
Oops, sorry, Frederike's title is Optical Coherence Tomography and NMOSD. Results from the CROCTINO cohort. Sorry, I mixed them up.
No problem at all. Is everybody able to see my screen?
No.
No, okay, then let's try again.
There it is.
Okay, great. So yeah, good morning everybody here at 7 a.m. So thank you very much for the opportunity to present today. I will, as Annika already said, present results from the CROCTINO cohort, which is a retrospective multi-center study in neuritis optica spectrum disorders. I have no disclosures related to this project. Optical coherence tomography is an imaging technique producing high-resolution cross-sectional images of the retina, and it recently became a great addition to the instrumental spectrum for diagnostics in neurology and neuro-ophthalmology. And probably most of you know OCT as a technique to quantify neuroaxonal damage after optic neuritis. And whereas in multiple sclerosis, optic neuritis is known to be a rather mild onset symptom and patients usually regain most of their function, optic neuritis in neuritis optica spectrum disorders is much more severe and frequent, and patients often suffer from complete vision loss and subsequent reduced quality of life. And 80% of NMO patients have antibodies against aquaporin-4 and astrocytic water channel. And these patients are, apart from the severe neuroaxonal damage after optic neuritis, suggested to actually also suffer from optic neuritis independent retinal changes. But unfortunately, because NMOSD is such a rare disease, all studies done so far are in rather small cohorts and have very conflicting results. And therefore, we did a multi-center study as part of the CROCTINO project, including 539 NMO patients and their retrospective OCT data, and 114 healthy controls from 22 centers to finally analyze optic neuritis dependent and independent changes in conclusively in the aquaporin-4 positive NMO. And if you have questions or like comments, you can interrupt me anytime, of course. So for the cohort, as I said, for our first analysis, we focused on aquaporin-4 positive patients. So we excluded all patients with a negative aquaporin-4 IgG status or not fulfilling the 2015 diagnosis criteria for NMO. We excluded all patients with relevant comorbidities, ophthalmological as well as neurological, which could potentially influence OCT results, such as glaucoma or intracranial hypertension. And we also excluded patients with more than 3 months between OCT and clinical visit to improve our data clarity and quality. And we excluded patients with less than 6 months between OCT and last optic neuritis episode, because at least for MS, we know that the neurodegeneration after optic neuritis is going on for around 6 months after optic neuritis. We actually don't know this for NMO, but we wanted to make sure that we really quantify the final quantity of neuroaxonal damage after optic neuritis. And then we excluded eyes with insufficient OCT data quality, and 3 patients from 1 center from Barcelona to end up with only 1 OCT device per center for our statistics. I will explain this in a second. So our final cohort consisted of 283 patients and 72 healthy controls, which were not matched. But we confirmed all comparisons with the healthy controls in a matched subset of 74 patients and 51 healthy controls. And as it was a retrospective study, we had data from multiple OCT devices. So we had Spectralis OCT data for 15 centers, Cirrus OCT data for 6 centers, and Topcon OCT data for 1 center. And for everybody of you who works with OCT, probably it becomes pretty clear that this might be a problem, because so far we were only able to analyze data device specifically, but not generally. But very recently, my previous group from Berlin published a work suggesting a new post-processing technique, which actually allows to analyze at least macular OCT data from multiple devices and combine them in a joint analysis. So in the lower right, for everybody who's not familiar with OCT, you can see an OCT, a macular OCT with the layers we were interested in. So the most upper layer is the retinal nerve fiber layer, which consists of all the axons and is usually measured in a ring around the optic nerve head. We were not able to combine the data from different devices for the NFL, so we're still working on a method to do so. But for both other layers, for the GCIP, the ganglion cell and inner plexiform layer, which contains the retinal ganglion cells, as well as the inner nuclear layer, which is the layer below and is suggested to be a marker of inflammation, we were actually able to combine the data from all devices into one analysis. We performed mixed linear effect models using the subject as well as the center as a random effect, and sex, age, and ethnicity as fixed effects. And we, as I already said, merged all data for the macular OCT data, so for GCIP and INL, and for the RNFL, we did separate analysis for the different devices, and then combined the data in kind of a meta-analysis using Fisher's z-test. So, coming to results, we first looked into GCIP as marker of neuroaxonal content. And as you can see in A, we compared healthy controls in gray on the left with non-optic neuritis eyes in blue on the middle and optic neuritis eyes in red on the right. And you can see, as expected, that there is a severe neuroaxonal degeneration after optic neuritis compared both to healthy controls and to eyes without a history of optic neuritis. And when you have a look at plot B in the upper right, you can see that this loss is most severe in patients or in eyes after the first optic neuritis episode, but the absolute as well as the relative loss after the second and every subsequent episode is much smaller and then even becomes insignificant. And going back to A, when we now look at the eyes without a history of optic neuritis, you can see that they have not such a big, but still an existing GCIP thinning compared to healthy controls. And we saw this in a smaller data set previously, but but it's still under discussion if there is optic neuritis independent GSIP loss in NMO patients. And a lot of critiques actually said that this might be caused by a contralateral optic neuritis episode, because optic neuritis in acupoint 4 IgG positive NMO is often very posterior and can include the chiasm, and therefore can lead to contralateral involvement. So what we did in this big data set is, and you can see this in C, we compared healthy controls to eyes without a history of optic neuritis and without a history of contralateral optic neuritis in light blue in the middle, with eyes without a history of optic neuritis, but with a history of contralateral optic neuritis in a darker shade of blue on the right. And you can indeed see that there is more pronounced GSIP loss in eyes with a history of contralateral optic neuritis, but both groups, so eyes with and without a history of contralateral optic neuritis, still have a thin GSIP compared to healthy controls, suggesting that there might be an optic neuritis independent pathology. Already said we had to split up the analysis for the different devices. And we were able to confirm the optic neuritis associated damage also for PNFL, but we didn't show any RNFL loss in eyes without a history of optic neuritis. And last but not least, we are also interested in the INL. Multiple works in multiple sclerosis suggested INL to be a marker of inflammation. So on the left, again, you can see the INL thickness in healthy controls in eyes without a history of optic neuritis and in eyes with a history of optic neuritis. And you can indeed see that there is a thickening of the INL in eyes with a history of optic neuritis compared to both other groups. But the eyes without a history of optic neuritis seem to not have a changed INL compared to healthy controls. And when you now look at B in the upper right, you can actually see that in NMO, the INL thickening is correlated to GSIP thinning. So there's a very good inversely correlation between these two layers. But this is more pronounced in eyes with a history of optic neuritis, here in red, and actually vanishes in non-optic neuritis eyes as well as in healthy controls. And apart from the thickening of the INL, the other pathological process in the INL is microcystic macular edema, which we also know from MS. Around 5% of MS patients actually have microcystic macular edema. You can see in C these black dots in the INL marked with arrows. These are these microcysts. And in our cohort, 7% of patients and actually 13%
Frederike, are you still there? I think we may have lost Frederike unexpectedly because I think a lot of us can't hear her and her screen has disappeared. She probably is frantically trying to log back in. So how about we just give her a few minutes just to try and get her back. While she's trying to get back in, would anybody like to comment on the results that we've been shown?
I'm so sorry.
Oh, there she is.
I'm so sorry.
It's okay.
When did I drop out? I didn't even notice.
You were busy discussing your graph with the INL GC.
Okay, I'm so sorry. Okay, let's go again. So I don't know, probably I talked about A. Yeah. So
yes,
we see a thickening of
A and
the
B.
We heard most of this, I think.
Yeah, and you talked about the microcystic edema.
Okay, I'm so sorry. So yeah, apart from INL thickening, the other pathological process in the INL is microcystic macular edema, which we also know from MS. Around 5% of MS patients suffer from microcystic macular edema after optic neuritis. And you can actually see this and see these black holes marked with arrows are the so-called cysts. And in NMO, in our cohort, we actually found a higher frequency with around 7% of patients suffering from microcystic macular edema and around 13% affected optic neuritis eyes. So, but the microcystic macular edema as well as the INL thickening was not different between groups with different numbers of optic neuritis episodes. So to conclude, we, in this big cohort of 283 patients, we were able to confirm a severe loss of retinal neuroaxonal content and an increase of INL thickness after optic neuritis. But we also underlined that there might be an optic neuritis independent GSIP loss, especially but not exclusively in fellow eyes after contralateral optic neuritis. And of course, the study so far lacks prospective and longitudinal data to actually confirm these effects. And we didn't do any direct comparisons to NMOSD other NMOSD subtypes, such as MOC-positive encephalomyelitis or multiple sclerosis. So we cannot say if the damage we see here is more or less severe than, for example, in MOC disease. And of course, we lacked healthy controls from all study sites. But yeah, we are working on improving these things, and I'm open to answer your questions. Thank you so much for your attention and your patience with my disruption. I'm very sorry.
Thanks, Frederike. That was excellent. Well done. And a good recovery there after we lost you. It's really good. Would you mind going back to just your main results slide? And then what we could, yeah, that one. So how about we opened it up for questions? Does anybody have a question to start off with?
So great job on the presentation. This is Jen Graves. As we've talked before, you know, the earlier data had shown no difference in RNFL loss in non-optic neuritis eyes and NMO. And do you think that what's important here is sheer numbers for why you guys are detecting this? Or do you think it's a difference between the ability to measure this in a GCIP metric versus an RNFL metric? And if so, could it be related to the macular pathology from the Mueller cells that we see in the fovea?
Yeah, thank you so much. That's a great question. So I think actually both facts can contribute to the effect we see. So I think on the one hand, the earlier studies always had a very, very small sample size, either suggesting or declining subclinical damage in optic neuritis. So I think that this definitely has an influence. I mean, there were also earlier studies, not only in RNFL, but also in GSIP, suggesting that there's actually only attack-related damage in NMO. But so that's one of the one side, but I think on the other side there might be also a process which we cannot fully understand yet, which leads to GSIP but not RNFL loss, because we previously did an analysis in a small data set with 50 patients showing GSIP loss but not RNFL loss, and at this time point we thought that it might be a sample size issue, but in this cohort here now, we see the same effect. So there might be a process we don't fully understand yet. And I think one potential point is definitely that there might be a direct macular process, which is not directly neurodegenerative, for example, including Muller cells or other astrocytic changes in the macular. But I think on the other hand, we also have to keep in mind that the RNFL is measuring the neuroaxonal content from the whole retina, so all axons going into the optic nerve, whereas the ganglion cell and inner plexiform layer is only measuring the change in the macular. So maybe we have a very specific change in the macula and not in the periphery, and therefore this effect is fading when we look into the retinal nerve fiber layer thickness. Does this answer your question?
Yes.
Okay, great.
Thank you, Frederike. Very nice talk. I was wondering if you have also for these patients like data about the burden of the disease in the rest of the central nervous system. So, for example, if you have some data about the lesion characteristics, if they had besides the optic neuritis, also lesions in the central nervous system, or in the, or I mean even atrophy, but I guess they were young patients too. If you have this data, and in case if you are going to analyze and see if there are any correlation with the OCT parameters.
Yeah, so actually thank you. This is a very exciting data set. So we have much more data. We have a lot of visual function data and also clinical data, which is unfortunately very heterogeneous because of the retrospective character of the study. And we also have a parallel study for which some but not all centers contributed, called PAM-RENO. And this was collecting MRI data as we collected OCT data. And it's definitely one plan to combine both studies to, for example, as you suggested, quantify lesion load or atrophy. But I think for the MRI study, it's even more difficult than for the OCT study to combine different protocols and different device MRI machines. So we don't have any results for this study yet, but you're completely right. So we have a good overlay between both studies, and we could definitely find a good subset of, I would say, around 200 patients to do a combined MRI and OCT analysis.
Wow. That's really good numbers. I was going to just ask one quick question. I was just thinking about the degree of GSIP loss that you're recording in both the optic neuritis and non-optic neuritis eyes, and just the threshold of change that you would expect potentially in a longitudinal study. Do you think the degree of loss that we already observe after 1 or 2 episodes is going to limit what we're going to observe over longitudinal follow-up, even if someone doesn't have a further episode?
Definitely. So I think that in our previous study with only 50 patients, this was a longitudinal study, and we actually saw this optic neuritis independent GSIP loss only in eyes without a history of optic neuritis, but not in eyes with a history of optic neuritis, which might be exactly this effect which you are suggesting, that the percentage loss might be the same, but the absolute loss is so small that we are actually not able to detect it. But in this previous longitudinal study, the optic neuritis independent neurodegeneration was actually comparable to MS studies, but it was not a direct comparison to MS patients, so we are not really able to conclude anything about the amount of optic neuritis independent neurodegeneration yet. But yeah, for optic neuritis dependent change, I think it's pretty clear that we have a much more severe optic neuritis with a much higher neuroaxonal loss in NMO compared to MS patients. So I think for MS, there are studies which are suggesting that already a sight difference of 5 to 10 micrometer is suggestive of optic neuritis, and in NMO you usually see much higher losses for up to 30 or 40 micrometer loss.
Great, thank you so much, Frederike. Frederike, that's really answers the question. Great job with the presentation. So we might move on to Sarah's presentation. There we go. So I'm pleased to introduce Sara Collorone, who is a clinical research associate at UCL Institute of Neurology at the Queen Square Multiple Sclerosis Center. And Sara is in the process of doing her PhD and is going to talk to us about work that she's done on visual function assessment and the brief cognitive assessment for MS or BICAMS in optic neuritis. So great. So Sara, if you could share your screen with us. There we go.
Yeah. So I hope everyone can see it.
Yes.
I also hope that I don't lose the connection. Let's see. So yes, I'm going to talk about visual function and cognition in early clinically isolated syndrome who had onset with a monoocular optic neuritis. And sorry, it doesn't. Yeah. So yeah, this is the outline of my presentation. So I'm just going to give a quick background, and then I'm go on with the aims of our study and methods and results. Yeah, so this is the background. So basically, cognitive deficits have been described since the early stages of MS. And if we look at clinically isolated syndrome, considering like tests that have used a control population assessed with the same battery or normative data, the presence of cognitive impairment is around 27%. But it varies a lot from study to study, and reviewing the data, it was interesting to note that even studies that look at very similar cohorts of patients, so CIS patients with 3-4 months from onset and at least 2 white matter lesions at the MRI, they found really different prevalence of cognitive impaired and patients, so that they were like the highest of the study at a frequency of 57% versus the 12.3% of the other study. And I mean, of course, they use like different batteries, and the patients may vary, particularly according to demographic factors, but we believe that there are also other factors that may be accounted for such differences, and particularly visual function can be also considered when thinking about cognitive impairment in CIS patients, as 1 in 5 of these patients has onset with optic neuritis. And indeed, there is a well-documented relationship in MS and multiple sclerosis between visual function and cognitive tests, both the ones that depend from visual input, as well as the ones that do not depend on visual input. And the first studies in MS, they were related to the high contrast letter acuity, and more recent studies, they have also looked at the association with the low contrast visual acuity, that we know is a more specific marker of visual disturbances in optic neuritis. And again, they found an association, particularly with the processing speed and the visual spatial memory, but also to tests that did not require visual input. However, in all these studies, we didn't have MRI data, and patients with MS were recruited like in the established phase of MS. So we don't know if we are just looking at a general damage accrual, like general physical disability, cognitive disability, and visual disability. When we go to look at the studies that investigated the relationship with OCT markers, so the markers of visual pathway damage, we have some, different results, inconsistent results. So we have one studies that didn't show any correlation with the peripapillary retinal nerve fiber layer and cognition. And in this study, patients with optic neuritis eyes were included. While in another studies, the study that found correlation between the thickness of the retinal layer and cognition, the eyes were excluded. So patients were still included if they had optic neuritis, but the eyes were excluded from the analysis. The GCPL, which is as we know, is a more reliable marker, it looks like that had correlation from these two recent studies. And interestingly, Frederike and colleagues, they excluded the optic neuritis eyes were excluded, not the optic neuritis patients. And so they divided the patients and tested differently patients, the eyes with the optic neuritis, and they found that only eyes without optic neuritis, there was a correlation with the GCPL, and not in the eyes with optic neuritis, where inflammation may have acted as a confounder in this relationship. However, similarly to what we were discussing before in these studies, there were no MRI data. So again, we didn't really know if there was a damage in the central nervous system in terms of brain atrophy, lesion load, lesion falling to the optic radiation that may have influenced this relationship. And here basically came the aim of our study, in which we wanted to assess the cognitive function after the onset of a typical demyelinating optic neuritis, so a CIS. And also we wanted to choose this kind of patients because in this case, in theory, we don't have a lot of disability accrual that may act as a confounder. And we wanted to test it in eyes with and without optic neuritis, including also markers of the central nervous system damage. So we recruited 42 patients with clinically isolated syndrome. We excluded patients with we tested in all the patients anti-aquaporin 4 and anti-MOG antibodies. So these patients were excluded, as well as other conditions, of course, affecting the central nervous system. And we also recruited 16 agent sex measured healthy controls. And this was the design of the study. So basically, patients were recruited within 3 months from onset. And they were first seen at baseline with OCT, MRI, and clinical assessments. And then they were seen at 6 months, which was 6 months as also what Frederike was mentioning. So in theory, is a time in which we can see most of the atrophy already, and there has already also been most of the recovery in optic neuritis patients. For this time, we repeated the MRI and as well as the CT and the clinical assessment. We assessed for the clinical disability, we used the EDSS, and then we chose to use BICAMS because basically it includes 2 cognitive tests, which are the BVMTR for the visual spatial memory, the single digit modality test for the processing speed, and then a test that does not require a visual input, which is the California Verbal Learning Test for verbal memory. And we chose BICAMS also because it's particularly used in the clinical setting because of its brevity, and not always, however, vision is assessed by clinician or researcher. So we wanted to know the impact on this test. Then, as regarding the visual function, we tested the high contrast and low contrast letter acuity, as well as color vision. We performed the CT, so RFNL and GCP with Heidelberg spectralis, using for the macular layers, we used the 1 to 3 millimeter inner circle of the 136 grid. And then we had a blind observer, a rater, who checked for the presence of optic neuritis in the MRI of their orbits, and so eyes that had like subclinical lesions were excluded. And finally, as I said, we wanted to measure also the damage. So we did the lesion volume and we also computed the volume of the lesions in the optic radiation, as well as atrophy and calcarine cortex thickness. So the scans were accepted according to the Oscar IB criteria, and in general, not only we discarded the eyes with subclinical evidence of optic neuritis, but in general also eyes that had an RFNL which was lower than 78 micrometers. For the statistical analysis, we used mixed effect models, and we computed the Z scores of the BICAMS using basically the parameter cohort, which is the cohort of MAC frames, and is the one used by the BICAMS platforms for the zeta score. In the affected model, in the mixed effect models, we account for demographical variables and also from the months from onset and from steroids. So our cohort was quite typical for age and sex distribution, and there were no differences with healthy controls. The disability was low and patients had no atrophy. 9 of the patients had dissemination in time and space, and thus they were fulfilling the criteria, the McDonald criteria 2017 for MS, and 3 further patients developed MS at 6 months. At 6 months, unfortunately, we also lost 7 patients at follow-up. When we went to analyze the cognitive function, basically patients were performing below the average for sex, age, and education in the single-digit modality test, and these did not improve over time. While for the visual spatial memory, they were performing below the average at baseline, but then they improved at 6 months. And California Verbal Learning Test performance was overall above the average, about a baseline, and at 6 months with an improvement, significant improvement between the 2 visits. So at the end, like considering our cohort, if you apply a threshold or 1.5 standard deviation below into at least 2 tests, comparing to the normative data, we would have had like 2% of patients impaired at baseline and 0 at 6 months. Now, regarding the visual function, our patients again were quite typical. So they had basically they showed a significant poor vision in the affected eye, both at the high contrast visual acuity as well as the low contrast visual acuity, and in the color vision. And this, interestingly, the high contrast visual acuity improved while the low contrast stayed compromised in the affected eye in comparison to the non-affected eye. And this was directly related to the GCP in the affected eye. So the patients that improved were the ones that had that showed less decrease in the GCP at 6 months, and similarly for the color vision. When looking at the interaction between cognitive outcomes and visual function, there was a correlation between the improvements that we observed in the visual spatial memory and the change in the high contrast visual acuity. While for the OCT, so we found that the RFNL showed a significant decrease at 6 months, while GCP, it was thinner in the affected eye in comparison to the non-affected eye of patients, but it was also thinner in the non-affected eyes of patients in comparison to healthy controls, and these values didn't change over time, so it stays like thinner without showing a further decrease, but we couldn't find any correlation between the OCT metrics and the BICAMS score, and we found no correlation also between the BICAMS scores and all the parameters that we have analyzed for the central nervous system damage. So lesion load, lesion number at baseline and 6 months, and lesion load in the optic radiation. So in conclusion, we observed in our patient that there was a specific impairment in the processing speed and in the visual spatial memory, which are two tests that require visual input. And this was independent apparently from the structural damage along the visual pathways and in the central nervous system. Now, as regards the speech processing, this is an impairment that in general is considered an hallmark for cognition in multiple sclerosis, and so it seems to be impaired very early. And interestingly, it was not dependent from the visual function or OCT metrics or central nervous system damage. So in this case, we think that probably other factors have to be taken into account, particularly from higher visual processing areas. So of course, in this sense, studies exploring functional connectivity or structural connectivity, they may be very interesting. Also, it's interesting to note that this deficit, not captured by the visual function, it can possibly be contributing to what is the subjective abnormalities that is often described by patients with optic neuritis even after the recovery. Concerning the visual memory, we found a correlation with the high contrast letter acuity, a correlation between the two recovery, and we think it's very interesting because, of course, once the test was assessed binocularly, why we had the data monocularly from the affected eye. And so we think that in some way it is possible that binocular stability or symmetry is needed for visual spatial memory. But also, I think that this gives also an interesting take-home message because, as I said, BICAMS is often used in observational studies in the clinical setting, and this shows that visual function, even just logMAR or high contrast letter acuity, must be taken into account. Otherwise, we risk to overestimate the other tests and underestimate the visual memory because it's affected by vision. And so as another interesting finding and controversial, we didn't find any correlation with the low contrast letter acuity. We were quite surprised, but then when looking at the other studies also, we think that it can be like that more in MS, like in the other study, really LA can be a surrogate marker of a more general neurodegenerative damage that was not present in our cohort. And so maybe at the very beginning of the disease, it doesn't show a direct relationship with the test, cognitive test, even the one visual related. Of course, further study can, must explore this relationship longitudinally to see if it changes over time. Of course, there were some limitations. Some patients started DMDs between the baseline and 6 months. And we couldn't account for this because of the small cohort, and also, of course, there is a training effect that we cannot avoid with such a short time between the two visits. So at 6 months, there should have been a training effect in the BICAMS test. So this was the conclusion of my talk. So thank you very much for listening. And I acknowledge the founders and the people of the unit.
Well done, Sara. That was a great talk. So I'll open this for a few questions. Does anybody want to start off?
Sara, this is Jen. Did you happen to measure binocular, and I'm sorry if I missed it, but did you happen to measure binocular summation? I think it was Stacy Pinellas with Laura Balser a while back had measured, and then maybe Heather Moss did some of this work too, but they had measured binocular summation in MS patients and demonstrated that there is a deficit in MS. And given some of the issues you just mentioned on the last few slides with relationship to cognition, just wondering if you measured that, if that was a strong correlation.
No, you mean binocular? No.
Binocular summation, which is to say that when in normal healthy controls, your binocular acuity can be better than your best eye. So in other words, if you're 20/25 in one eye and 20/30 in the other eye, it might be possible for you to be 20/20 with binocular testing. So there's a phenomenon of binocular summation, and they've shown previously, although I think they were still modest sample sizes, but they've shown previously, Balser and some of the fellows that were back at Penn had done some work showing that in MS, that summation process is affected. So an MS patient won't have that benefit, or at least on average, will be less likely to have a better binocular acuity than monocular acuities compared to healthy controls. And I'm wondering if that phenomenon is contributing at all to what you're seeing.
Yeah, we didn't measure it. It's an interesting point. We measure only the visual function monocularly, and then we consider each eye separately. This was also to find the correlations also with the CT, but we did not assess the vision binocularly.
It would be something interesting to look at in your next work.
Yeah, definitely. Thank you.
Sara, can I ask, with the BVMTR, did you look just, cross-sectionally at the time point? So looking at the BVMTR and logMAR acuity at baseline compared to the measurements at 6 months between the different measures, rather than plotting the change, because it's hard to interpret the BVMT, with the practice effects that you're observing. Did you just look at those time points?
Yeah, so we looked at both. We look at we did a longitudinal model with mixed effect models. So to check if there was an interaction between the slopes of the improvement, although we had just two time points. Yeah. And then we also looked at the different, so at each time point separately. And so we found, yes, a correlation basically between the improvement in the vision and the improvement in the BVMTR.
Okay.
But no correlation like at baseline or at 6 months.
Yeah, I guess it would be, I guess the interesting question would be to know if there's a threshold where there's a threshold of visual acuity where you cannot use a cognitive test like the BVMTR because of the afferent problems that you might be experiencing.
Yeah, so, it's very interesting. And as also Jen says, maybe also looking at binocular, because of course these were patients that if assessed in the clinical practice or even in an observational study, like on CIS, they would have had a normal binocular vision, and so they would have just undergone the tests normally without any correction. I think it's, I think if we're going to look at the binocular acuity, I think they maybe don't have relationships with the cognitive tests, the ones that require visual input, but of course it's something to explore and to test, and also so in a way to check, as I said, if there is a cutoff also that can be used in the clinical practice, for example, if BICAMS is assessed, or in observational studies on CIS, where often cognitive outcomes are used in general.
Yeah. No, it's great, great work, very interesting. Does anybody else have a question? What? Look like everybody's gone quiet. All right. So I think we might wrap it up then at that point. Thank you so much to our presenters, to both Sara and Frederike, for presenting your work. And thanks to everybody who dialed in to our meeting. I think we had 11 participants there at one point. So that is fantastic, given that we all scattered around the world. We look forward to hosting some more of these meetings, of course, in the future, and you'll see the emails come out. As for this particular meeting, it was recorded and it will be posted in a couple of days on the iWiMS.world website, and the link will be sent out. So we can all have another look and a think about this interesting work. So I might wrap it up there. Does anybody, maybe we should just all quickly switch our videos on and say hi.
Hi.
Thank you so much.
Thank you so much, Marie.
That was just really good. Well done.
Have a great day.
Thanks, everyone.
Bye.
Take care.
Bye.
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 Bye. Thank you.